I'm so glad you're all here. We're so pleased to bring you this event today. We are bringing to you the Community Civic Association is proud to present our featured speaker, Dr. Sadeghi, and she's with Saddleback Medical Group over here in Laguna Hills, and she has a table back there if you need any additional information after the presentation. We'd ask you to please put your cell phones on silent, just a reminder. And we do have coffee and water, and later on we'll be serving lunch. So if does anybody need to know where the restrooms are? If so, it is down the corridor here for anybody that needs to use the restroom. So we are taping this event, and just to let you know, we'll be taping the event. So if you need anything or need to speak to me, feel free to come outside into the corridor and speak to me. So at this point, we'd like to ask everybody to stand, please, for the Pledge of Allegiance. Okay, we are going to. The flag is behind here usually. Like this? Got it. Okay. Thank you, everybody. So if you put your hand over your heart, I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. I apologize, we don't have the flag. Take a seat. So at this point, I'd like to welcome Dr. Mehar Sadeghi. Come on up. Let's give her a hand, please. Should I use this or that? Either one, I would.
Okay. Hello, everyone, and welcome. Not working?
Testing. Much better.
Hi, everyone, and welcome. I'm Dr. Sadeghi. I'm board certified in internal medicine, and I'll be talking a little bit about diabetes today. I'll be covering what diabetes is, the symptoms of diabetes, how diabetes is diagnosed and treated. So diabetes is a group of diseases characterized by high levels of blood sugar resulting from defects in insulin production, insulin action, or both. The term diabetes describes a metabolic disorder of multiple etiologies characterized by chronic hyperglycemia or elevated levels of blood sugar with disturbances of carbohydrate, fat, and protein metabolism resulting from defects in insulin secretion, action, or both. For instance, with diabetes type 1, we're dealing with defects in insulin secretion, but with diabetes type 2, it's mainly about the insulin action that's not appropriate. The effects of diabetes include long-term damage, dysfunction, and failure of various organs. Diabetes may present with characteristic symptoms such as thirst, polyuria, blurring of vision, and weight loss. In its most severe forms, ketoacidosis or a non-ketotic hyperosmolar state may develop and lead to stupor, coma, and in absence of effective treatment, even death. But often, symptoms are not severe or may even be absent, and consequently, hyperglycemia sufficient to cause pathological and functional changes may be present for a long time before the diagnosis is made. This is why screening is so important, because diabetes can go silent for so many years, cause damage, and by the time it's diagnosed, patients already have complications. The long-term complications of diabetes include progressive development of the specific complications of retinopathy. It affects the eyes, causes retinopathy with potential blindness. It affects the kidneys with nephropathy that may lead to renal failure. It also affects our nervous system and causes neuropathy with the risk of foot ulcers, amputations, Charcot joints, and features of autonomic dysfunction, including sexual dysfunction. The autonomic dysfunction also affects the gastrointestinal nervous system and can cause gastric paresis and gastrointestinal symptoms and complications. People with diabetes are, of course, at increased risk of cardiovascular, peripheral vascular, and cerebrovascular complications. Per a report by the CDC in 2017, more than 100 million adults in the US are now living with diabetes or pre-diabetes. Per the same report, nearly 1 in 4 adults living with diabetes didn't know they had the condition, and only 11.6% of adults with pre-diabetes knew they had it. This is, again, why screenings are so important. In 2015, diabetes was the 7th leading cause of death in the US. There are several types of diabetes: type 1, type 2, gestational, and some other more rare types, such as latent autoimmune diabetes in adults, maturity onset diabetes of youth, and secondary diabetes. Type 1, which was previously called insulin-dependent diabetes or juvenile onset diabetes, develops when the body's immune system destroys pancreatic cells. Those are the only cells in the body that can make insulin, which regulates the blood sugar. This form of diabetes usually strikes children and young adults. And type 1 diabetes accounts for about 5 to 10% of all diagnosed cases of diabetes. The risk factors for type 1 may include autoimmune, genetic, and environmental factors. We don't know for sure what causes type 1 diabetes, but we think it's a combination of all these factors. Type 2 diabetes, which is the most common type, was previously called non-insulin dependent or adult onset diabetes. Type 2 diabetes accounts for about 90 to 95% of all diagnosed cases of diabetes. It usually begins as insulin resistance, a disorder in which the cells do not use insulin properly. As the need for insulin rises, the pancreas gradually loses its ability to produce enough insulin. Type 2 diabetes is associated with older age, obesity, family history of diabetes, history of gestational diabetes, impaired glucose metabolism, physical inactivity, and race or ethnicity. African Americans, Hispanic or Latino Americans, American Indians, and some Asian Americans and Native Hawaiians or other Pacific Islanders are at particularly high risk for type 2 diabetes. Unfortunately, though, type 2 diabetes is increasingly being diagnosed in children and adolescents because of the increase in obesity in that group. Gestational diabetes is a form of glucose intolerance that is diagnosed in some women during pregnancy. It occurs more frequently among African Americans, Hispanic, Latino Americans, and American Indians. It's also more common among obese women and women with a family history of diabetes. During pregnancy, gestational diabetes requires treatment to normalize maternal blood glucose levels to avoid complications in the infant. After pregnancy, about 5 to 10% of the women with gestational diabetes are diagnosed with type 2 diabetes. And women who've had gestational diabetes have a 20 to 50% increased risk of developing diabetes in the next 5 to 10 years. There are some other specific types of diabetes. They result from specific genetic conditions such as maturity onset diabetes of youth, surgery, drugs, malnutrition, infections, and other illnesses. Such types of diabetes may account for 1 to 5% of all diagnosed cases of diabetes. I'm not going to dive into these rare types of diabetes, but I do want to mention one specific type, which is the latent autoimmune diabetes in adults, or LADA. It's a form of autoimmune disorder, so it's very much like type 1 diabetes, but it's diagnosed in individuals who are older than the usual age of onset of diabetes type 1. So in that sense, it's more like type 2 diabetes. Other terms that have been used for LADA include late onset autoimmune diabetes of adulthood, slow onset type 1 diabetes, and sometimes also type 1.5. Often patients with LADA are mistakenly thought to have type 2 diabetes based on their age at the time of diagnosis. Now, this specific type of diabetes is important because 80% of adults apparently with recently diagnosed type 2 diabetes, but with certain autoantibodies, they progress to insulin requirement within 6 years, most of them even earlier than that. The potential value of identifying this group who are at high risk of progression to insulin dependence is the avoidance of using metformin treatment. And that's important in this group because metformin can lead to a very serious complication called lactic acidosis. And also, it's important to identify these patients so that they can early on be started on insulin therapy, and insulin in this group helps to preserve the function of the pancreas and preserve the beta cells. Now, most of our patients have prediabetes. Prediabetes is a term used to distinguish people who are at increased risk of developing diabetes. People with prediabetes have impaired fasting glucose or impaired glucose tolerance. Some people may have both. Impaired fasting glucose is a condition in which the fasting blood sugar level is elevated after an overnight fast, but it's not high enough to be classified as diabetes. Usually the fasting blood sugar for prediabetes is 100 to 125. Impaired glucose tolerance is a condition in which the blood sugar level is elevated after a 2-hour oral glucose tolerance test, but again, not high enough to be classified as diabetes. So usually it's less than 200 milligram per deciliter. Progression to diabetes among these patients is not inevitable, and studies suggest that weight loss and increased physical activity among people with prediabetes can prevent or at least delay diabetes onset and may actually return blood glucose levels to normal. It's important to discover these patients early because people with prediabetes are already at increased risk for other adverse health outcomes such as heart disease and stroke. Now, how do we diagnose diabetes? Well, if a patient presents with classic symptoms of high blood sugar, such as thirst, polyuria, weight loss, blurry vision, and they have a random blood glucose value of 200 or higher, it's easy to establish the diagnosis. But most of our patients come in and they're asymptomatic. In those patients, a fasting plasma glucose value of above 126 or a 2-hour plasma glucose value during an oral glucose tolerance test of above 200 or A1C values above 6.5 are diagnostic. Good news is we can prevent and delay, and in some cases even reverse diabetes. And it's done mainly through lifestyle modifications. Research studies have found that lifestyle changes can prevent or delay the onset of type 2 diabetes among high-risk adults. The lifestyle interventions looked at included diet and moderate intensity physical activity, such as walking, for a total of 2.5 hours each week. In the diabetes prevention program, which was a large prevention study of people at high risk for diabetes, the development of diabetes was reduced by 58% over 3 years. Our nutritional goals for people with type 2 diabetes should aim at maintaining blood sugar levels as near normal as possible by balancing food intake with activity and medications or insulin, to achieve optimal blood pressure and lipid levels, provide appropriate calories for achieving and maintaining a healthy, desirable body weight, manage risk factors and prevent complications of diabetes, and of course, to feel good and have more energy. I often get this question, what can I eat if I have diabetes? The key to eating with diabetes is to eat a variety of healthy foods from all food groups, and the food groups include vegetables, fruits, grains, protein, and dairy. When it comes to grains, at least half of your grains for the day should be whole grains. Protein, except for obviously meat and chicken and turkey and fish, includes nuts and peanuts, dried beans and certain peas, such as chickpeas and split peas, meat substitutes such as tofu, and dairy should be non-fat or low-fat. We should eat more foods with heart-healthy fats, or the ones called polyunsaturated fats. These fats are mainly from the plant world, but also from fish. Oils that are liquid at room temperature, such as canola and olive oil. Nuts and seeds. Heart-healthy fish, such as salmon, tuna, and mackerel. And avocado, all have polysaturated fats. There is some evidence that replacing saturated fats, and saturated fat is mainly the fat that comes from animals, with polyunsaturated fat reduces fasting blood sugar, A1C, and insulin resistance. And also that replacing carbohydrates and saturated fats with polyunsaturated fats improved insulin secretion. When it comes to daily fat intake, it's more important what type of fats we eat than how much. But the general recommendation is to limit dietary saturated fat. It should be less than 10% of total calorie intake. Cholesterol should be kept to less than 300 milligrams per day. And trans fats should be avoided. Trans fats are the chemical fats, the type of fats that are produced when we fry foods. Protein intake should be 0.8 to 1.3 gram per kilogram body weight per day, or 10 to 20% of total calorie intake. What foods should we avoid or limit? Of course, fried foods and other foods that are high in saturated fat and trans fat. Foods high in salt or sodium, daily salt intake should be less than 2,000 milligrams per day. Sweets such as baked goods, candy, and ice cream. beverages with added sugars, such as juice, regular soda, and regular sports and energy drinks. I often tell my patients, you can have fruit, but avoid fruit juice. Alcohol should be limited for a number of different reasons. This is another common question that I get. How much can I eat if I have diabetes? Two common ways to help plan how much to eat are the plate method and carbohydrate counting. I'm going to tell you a little bit more about the plate method because that's really how all of us should eat, not just people with diabetes. It helps to control your portion sizes and you don't need to count calories. So picture a 9-inch plate divided by half, and half of the plate should be your non-starchy vegetables. Starchy vegetables are potatoes, sweet potatoes, corn, sweet pea. The other half of your plate, you divide by another half. 1/4 of your plate will be protein. Stay with lean protein like chicken breast, turkey breast, fish a few times a week, or plant-based protein or meat substitute like tofu. The other 1/4 of your plate will be your carbohydrates. In that portion, you can have your starchy vegetables, and you can also have your grains, which should be whole grains. Weight loss is a very important part of both prevention and treatment of diabetes. With weight loss, we do achieve improved glycemic control, and that improved glycemic control is associated with at least partial correction of the two major abnormalities in type 2 diabetes, which is insulin resistance and impaired insulin secretion. So with weight loss, we decrease insulin resistance and also adjust insulin secretion. For patients with type 2 diabetes who are overweight, meaning they have a BMI above 25 to 30, or obese, meaning a BMI above 30, the initial recommendation for weight loss and physical activity is to lose 5 to 10% of initial body weight and to do at least 30 minutes of moderate physical activity most days of the week. I often tell my patients to try to walk at least 10 to 15 minutes after each meal. By doing that, you instantly bring down your post-meal blood sugar, and you also get in the 30 minutes of exercise that's recommended daily. A lot of my patients ask, so how much should I weigh? There are many different ways to calculate a healthy body weight. Often we use BMI, which is basically weight to height ratio, but this is an easy way to estimate a healthy body weight. For women over 5 feet, start with 100 pounds and add 5 pounds for each additional weight. For women under 5 feet, again start with 100 pounds, but subtract 5 pounds for each additional inch under 5 feet. For men over 5 feet, start with 106 pounds and add 6 pounds for each additional inch. So how much calories do we need every day? This is an easy way to roughly estimate our daily calorie needs to maintain our weight. For most men and active women, we need 15 calories per pound. Most women, sedentary men, and adults over 55, 13 calories per pound. Sedentary women and obese adults, 10 calories per pound, and pregnant or lactating women between 15 to 17 calories per pound. So for instance, a sedentary woman or an obese adult that weighs 200 pounds, they would need 2,000 calories per day to maintain their weight. Now to estimate how much calories is needed for weight loss of 1 to 2 pounds per week, you can subtract 500 to 1,000 calories from the weight maintenance calories. So that same person that needed 2,000 calories to maintain their weight they need to reduce their daily calorie intake to at least 1,500 per day to lose 1 pound per week. I don't recommend to subtract more than 500. When we subtract more than that, and especially 1,000 calories, we often go into very low calorie diets, which can have complications. It's difficult to get adequate daily calorie needs and also to meet the nutritional needs. And those type of low calorie diets should be done only under physician supervision. I'm going to talk a little bit about pharmacologic treatments of type 2 diabetes. For type 2 diabetes patients with A1Cs less than 7.5 at the time of diagnosis, we can often allow them 3 to 6 months of aggressive lifestyle changes and see if they can achieve glycemic control without medication. But if their A1C is 7.5 to 8% at time of diagnosis, we often need to start them on medication along with lifestyle changes. Metformin is a preferred initial therapy because it's effective. There is no weight gain or hypoglycemia associated with metformin. It's generally well tolerated and it's cheap. Metformin works by decreasing liver sugar production and also intestinal sugar absorption, and it also increases insulin sensitivity, which is the biggest problem with type 2 diabetes. It doesn't have adverse cardiovascular effects, and in fact, it appears to decrease cardiovascular events. Now, for patients who can't tolerate metformin or have contraindications to it, alternative medications are often chosen, guided by patients' comorbidities, in particular presence or absence of cardiovascular disease. There are two newer groups of anti-diabetic medications that we often use in patients that don't tolerate metformin, or if we have to add another medication to metformin. The first group is what we call glucagon-like peptide 1 receptor agonist, or GLP-1 receptor agonist. That group includes Victoza and Saxenda or Ozempic. We tend to use this group especially in patients with evidence of atherosclerotic cardiovascular disease, because it's been shown to reduce morbidity and mortality in that group of patients. These patients often have higher A1C. They're motivated to lose weight. These medications can help with weight loss. And patients need to be able or willing to inject themselves because these are all injectables. They work by increasing insulin secretion. They decrease glucagon secretion. Glucagon is the hormone that increases sugar production by the liver. And they also delay gastric emptying. The other group is the one called sodium glucose cotransporter 2 inhibitors. In that group, we have Jardiance, Farxiga, Invokana. We tend to choose this group when we have patients with heart failure or early stage chronic kidney disease, as this group has been shown to reduce morbidity and hospitalization in heart failure patients and also progression of chronic kidney disease. They work by reducing glucose reabsorption and increase urinary glucose excretion. I'm not going to go into their specific side effects, but as I said, they're newer medications, so long-term efficacy or long-term safety hasn't been established yet, but they seem to be very efficient. For patients who are symptomatic or have severe hyperglycemia, and hyperglycemia is defined as fasting glucose above 250 or random glucose consistently above 300, or A1C above 9.5%. If those patients have ketonuria or weight loss, they need to be started on insulin right away. However, if a patient with severe hyperglycemia is asymptomatic and doesn't have either ketonuria or weight loss, we can choose either insulin or the GLP-1 receptor agonist that I just talked about, with or without metformin. And in most cases, we tend to use metformin because it reduces insulin resistance, and by that lowers the necessary, the needed dose of insulin. There are additional groups of anti-diabetic medications. The sulfonylureas have been on the market for many years, and they used to be one of the first hand choices, but with the newer groups of medications, we tend to not use them that often anymore. That group includes glipizide or glimepiride. They work by stimulating insulin release from the pancreas. Their major disadvantages are weight gain and hypoglycemia. TZDs, which include pioglitazone, Actos, rosiglitazone, they increase insulin sensitivity. Their disadvantages include fluid retention and even heart failure, weight gain, and bone fractures. Glinides, in the US, repaglinide or Prandin is available. They stimulate insulin release. Their main disadvantages include weight gain, hypoglycemia, and the fact that they have to be dosed 3 times a day. A newer group is the DDP4 inhibitors, which includes Januvia, Tradjenta, Onglyza. They work by increasing insulin release and decreasing glucagon levels. They're generally well tolerated, don't have many side effects, but the long-term safety, again, is not established. At the end, I would like to go over the symptoms of hypoglycemia, because hypoglycemia can acutely become very dangerous. If severe and untreated, it can lead to coma or death, where hyperglycemia is more dangerous over a long period of time. The symptoms of hypoglycemia are sudden and range from mild to severe. It can be excessive sweating, tiredness, feeling dizzy or weak, being pale, a sudden feeling of hunger, increased heart rate, blurred vision, confusion, being irritable or nervous, slurred speech, tremor, nausea, or vomiting. Symptoms of hypoglycemia during sleep include having nightmares, excessive sweating, feeling tired, irritated, or confused after waking up. That's all I had for today. I'd like to thank you for attending, and if you have any questions, I'll be happy to answer them now. So, oh. There you go. So the question was, normal range of fasting blood sugar goes up to 99. What happens if you're just one step above it, 100? So then it's the very beginning of the pre-diabetic range. Pre-diabetes is 100 to 125. That may not be so bad if you're only one step above, and a lot of times we repeat that test because it could still be within the lab error. However, if you're always a few steps above the normal range, we should start thinking about lifestyle modifications and try to bring that blood sugar down. The truth about these ranges, both with the fasting sugar and with A1C, is that we don't know the exact safe level. Over the past years, the upper normal limit has been lowered. When I was in medical school, normal glucose was much higher than what it is now. And I suspect in the future it might be changed again. The reason they're in place is because a group of doctors sat down and they were forced to pick a number, so they picked 99 and they picked 6.5. But any number in close to that range should be taken seriously. Well, I wouldn't worry so much about that. What if it's always 99?
I know that this is really quite serious right now with the amount of diabetes that we're having. And also my, obesity, overweight, being sedate, not getting exercise, we do know that that's not going to help anything. I guess I was not aware that there are certain ethnicities that struggle with this so much more. Do we know why that is?
It's just the genetic component of it.
Okay, so it doesn't necessarily have to do with the type of diet they have, or does it?
It does. It does. Because, for instance, if you look at a lot of Pacific Islanders, they also tend to have a lot more obesity and morbid obesity. So it does have to do with diet, but also a lot of genetic components. But weight control is crucial in prevention of diabetes and also reversing it and treating it.
Would that then, because of the Mediterraneans, have more of the good oils, the good fats that do not have?
Absolutely. Like I said, when you switch some of the bad fats, the saturated animal fats, for the good fats, the polyunsaturated omega-3s, that's a lot in the Mediterranean diet, you actually change the metabolism of sugar. You decrease the fasting sugar, you decrease insulin resistance, A1C, and also can increase insulin production. So all those changes can lead to prevention of diabetes, but also reversal of diabetes.
One last thing before, because there's a lot of pancreatic cancer that is getting, does that have they had diabetes? Has that got anything to do with that at all?
There is no clear association between diabetes and pancreatic cancer, no. Anyone else? Yes? Pre-diabetes? Yes. Absolutely, it can definitely be your diet. Also, one thing to think about is you probably should have regular screenings and make sure that you don't develop diabetes because like you said, you're not overweight, you don't have family history necessarily, and it could be one of those rare cases with a latent autoimmune adult onset diabetes.
Well, thank you so much for your wonderful lecture. It really gave so much information about the diet and the disease itself. My question is about the beans that, where do they fall into? What type of beans and,
So,
vegetarian diet?
Absolutely. So beans and such, they fall into the plant-based protein. And those are actually recommended.
Oh.
Yeah, so a vegetarian or vegan diet is actually a good diet for diabetes, even though you get a lot of fruits and such, but still it helps to control because you avoid the bad fats in general. It helps to improve diabetes.
Thank you.
Hi, I'm a health and wellness coach, and also I'm co-chairing a group here called Non-Toxic Laguna Woods, and I'd like to offer some additional information that I think is very, very important. We should all immediately stop ingesting soy products because there is no way that organic soybeans can actually be proven to be organic anymore because Monsanto sprays and the farmers spray also. They use aerial spraying, and I personally know of a family that had an organic soybean farm that was put out of business because there's no way that you can segregate the air. And the farms in their neighborhood were also being sprayed with Monsanto's Roundup, and they could no longer guarantee that their soybeans were definitely organic and non-GMO. So my advice is stop buying and ingesting soy products. They are really dangerous. Roundup is, as you probably know from reading the news and knowing about the lawsuits that have been successful against Monsanto/Bayer, there are going to be thousands more. So that's my advice. And also, canola oil, there's no such thing as a canola plant. Canola oil stands for Canadian oil. That oil is made from rape seeds. So I definitely do not recommend ever, ingesting canola oil. And most restaurants use it. Most catering services use it. It's cheap.
Thank you very much. Okay. Any other questions? Okay. Our last question.
How about the cracked wheat is better than eating like Indian wheat roti?
I'm sorry, I just couldn't hear you.
Yeah, cracked wheat, make like a use lentil and cracked wheat is better eating that than eating Indian bread.
So, yes. If cracked wheat and lentils and such is better than regular bread,
Yeah.
that's the question. Yes. So we do recommend whole grain, whole wheat, cracked wheat, lentils and such are definitely recommended.
Thank you very much. Thank you all for your questions. Let's give Dr. Sadehi a round of applause. Thank you so much.
Thank you.
Thank you again, Dr. Sadehi. Sure. There we go. Okay, so at this point in the program, I hope you've all enjoyed our presentation on diabetes. It's when we go to the doctor, we usually don't get that much time, and so we hope in these lectures that you're able to get some more information that can really help change your lifestyle and improve your quality of life. The CCA is a membership, and so outside you're going to see a form that we have for the membership that talks about some of the things we can bring. And so if you would take a minute and look at that, if you didn't get one, you can raise your hand and we'll bring you one. We want to see what you're interested because in addition to health and wellness, there's a lot of other things here in the village that you might be interested that we can bring to you in our sessions. Oh boy. So, but with that, what we'd like to do right now is also get ready. We're going to bring up our sponsors, and then we'll have our hypnotherapist come. And then, so if we can have our sponsors come on board real quick. We'll take a quick break right now and just do a little recognition because as we transition to a membership club, we are able to pay for this using our sponsors. So come on up, sponsors. Thank you very much. And some of them have some really interesting information, some integrated wellness, things like that. And then come on board, come on up here. And ma'am, I'll take your question in just a minute. Come on up. And if you can somebody can come right over here. Okay, so first we're going to introduce, this is Debbie Burke from Memorial Care Palliative and Hospice. Thank you, Debbie. Come on over.
Thank you. Thank you very much. This was really a very informative lecture. Thank you, Dr. Sadeghi. And it's always really nice to be part of Laguna Woods for education. And I'm always so impressed how everybody comes to learn more about things and new things. And our program, everybody knows about hospice. It's been around forever. It's a wonderful program for people who need help at the end of life. Palliative care is a little bit different. Palliative care is for people who have a disease with a chronic issue and need some help at home on symptom management, goals of care, and can be covered by your insurance. Typically, there is no charge to the patient. But palliative care is like the new buzzword. It's a really great program for people who do have symptoms that need to be managed. You can continue to see your physician. You continue to get aggressive treatment. Always the goal is the patient to keep them comfortable out of the hospital and know that there's support there whenever you need it. So thank you very much. Thanks, Lisa.
Thanks, Deb. And now we have Beverly and Tammy who are going to talk to you about Reiki healing.
Hi, I'm Beverly Enright. I'm a registered nurse and a certified Reiki 2 practitioner. And with me is Tammy Dakota. Tammy is a very experienced Reiki master and instructor. And she's been doing this for years. She was my instructor, so she's great. How many of you know what Reiki is? Just raise the hand. Some of you stopped in the back table by us and come and visit us. Reiki is an ancient Japanese form of healing using hands over, hands on technique. Reiki is spelled R-E-I-K-I. R-E-I, means God's wisdom or power above. Ki means life force energy. So it's a spiritual healing of life force energy. This energy is used in a variety of different areas. They use it in hospital. I know that some surgeons use it as a preoperative treatment before the patient goes into surgery to have better success after surgery. So that's kind of a new and upcoming thing that's going on, as well as using it in other therapeutic areas to go along with other treatment modalities. Reiki is used for a variety of purposes, all physical, spiritual, emotional. It enhances better recognition and decreases stress, helps with sleep, promotes a better, more peaceful sleep, helps with alleviation of pain. It also promotes inner healing, and the immune system kind of gives it a boost of the immune system. So what it does is that we remove the blockages of our energy centers or chakras that are in our body, and they innervate or they work with our organs as well as our spiritual and emotional aspects of life.
My turn.
Thank you.
Okay, her turn. Okay, I'm sorry.
Come see us.
Come see us in the back.
Thank you. Thank you very much.
Thank you. Go this way. Oh.
Thank you very much. And now I'm going to introduce Bick Herring, who's going to talk to you about her cancer screening.
Hi, my name is Bick Herring. I'm a cancer screen advocate with HMA Genetics. And did you know that 1.7 million Americans are diagnosed every year that they have cancer? So I'm here to share you how you can detect cancer early so that you can prevent from getting cancer. And also, Medicare Part B and any PPO plan of the managed care is covered at 100% at no cost to those who qualify. So come see me at the back table and see if you can qualify for that. Thank you.
Thank you, Bick. Let's give her a hand. Thank you. And one of the co-founders of the CCA, Karen Pollock with Nikon Wellness.
Good afternoon. I've been with Nikon for over 22 years. Their products have helped me where nothing else worked.
Karen.
Oh, okay. I've been with Nikin for over 22 years. They've helped me where nothing else has worked. In fact, when I got started with Nikin, I had a frozen shoulder for 4 weeks. I was seeing 2 doctors for 3 weeks, and nothing worked until a second doctor, who was a chiropractor, said, let's try magnets. So I put these magnetic insoles in my shoes, and 2 hours later, I had full range of motion. I got hooked on magnets real fast, and I've been helping people ever since. Magnets have been used for centuries. They are the most affordable, the safest form of pain relief you can use. We have them in sleep systems, jewelry, in our water. We also have a nutritional line that is pharmaceutical grade, and many other products. So if you want to know more, I am a resident of Laguna Woods, and I can come to you. Thank you.
Thank you, Karen. And then the CCA just wants to, we'd like to formally recognize our volunteers. Without our volunteers, many of these things just can't happen. So Deborah Pearson is a longtime supporter of the CCA in Laguna Woods, and I just want to just give her a few minutes to thank her and let her come take the floor and talk to you a little bit about what she does. Thank you. Thanks, Deb.
Can you hear me? Okay. Well, thank you for having me, and it's always my pleasure to be here and support the CCA. What I'm really thrilled and excited about is I have just landed a new position at 1OC. My position is called the RSVP Manager. RSVP stands for Retired Seniors Volunteer Program. So I'm really excited in collaboration with nonprofit organizations and companies. I will be recruiting seniors to volunteer and make an impact on our community. So thank you.
Thank you, Deb, so much. Okay, well, at this point in the program, we are going to bring up, how many of you have heard of hypnotherapy? Right? During promoting this event, I learned so much about it. Modifying risk factors is very hard for those of us with chronic disease. It's very important. People will say, just lose weight, just stop smoking, get better sleep, try to follow a diet, try to do things. Some of these things are very difficult, and I've heard several testimonies that say, you know, I'd like to give it a try and hear more about it. We use animal therapies and music therapy in our hospice and palliative over at Memorial Care and things of that nature. So I'm really excited to bring up our next speaker, who is going to be talking to you. He is a certified hypno coach, and let's welcome Jonathan Fisher. Thank you, Jonathan.
Okay. Now, in a few moments, you're going to notice your right arm from the fingertips to the elbow will start to become a little bit lighter and actually begin to lift and rise into the air, a lighter and lighter feeling. This is what she said to me. So my eyes are closed, I'm sitting at a desk, and my arm is on the table. And she's repeating this, lifting and rising, floating up, drifting up. But she's not the only one saying this. About 15 other pairs of students, of classmates of mine, are also saying the same thing, but in their different order. It's going to lift and rise, floating up, higher and higher. But then they're saying other things too. They're doing the pre-induction speech, as we call it. So they're saying, well, hypnosis is all self-hypnosis, meaning you can't be hypnotized unless you want to be hypnotized. So it's not a losing of control, it's actually a gaining of control. And somebody off to my right, as my eyes are closed, I'm hearing all these different voices, goes, actually, in hypnosis, you can't be made to do something or believe something that's against your morals, your personality, your ethics. You give the suggestion, and you don't want to do it, you just wouldn't do it. Meanwhile, she's lifting and rising higher and higher, and my arm is just sitting there. Somebody else over here is like, and really all hypnosis is focused concentration, often paired with deep relaxation. So I'm hearing that, and somebody else is talking about, very enthusiastically, she goes, so have you ever been in a car and you're driving down the freeway, and you're so engrossed in your thoughts or whatever, and you forget your exit? How many of us have done that? That's hypnosis. Or how many people have driven someplace you drive all the time, and you get there, you go, I don't actually remember driving. So she's telling the story as I'm sitting there lifting and rising, higher and higher, my arm is not moving. So I'm hearing all these different descriptions. And somebody else goes, hypnosis, in hypnosis you might hear the words sleep, or you might hear the words deep sleep, but you're not asleep in hypnosis, it's not like that. In fact, when you're hypnotized, you'll be more aware of things around you. So with your eyes closed, sometimes you're like, oh, I hear the air conditioner. I hear things in the other room. You're actually more aware, hearing everything what the hypnotist says when you're in hypnosis. It's not this place you go and then come back from. A little bit different than what people think. But again, I'm sitting there. My arm's not going up. And now I'm thinking, we're paired up. It's her first time hypnotizing anybody. So I'm like, yeah, I'm going to help her out a little bit. So I've seen arms go up before, and I'm thinking, I know what it looks like, so I kind of jerk my arm up. And it's convincing. And I can just hear in her voice, she's excited, but doesn't really show it. She's like, oh, so lifting and rising higher and higher. So I'm like, okay, it's going up. So here's the thing. We've all been taught it's this arm-raising induction. The arm doesn't have to go up. It doesn't have to go up. It's really cool if it does, and especially for her first time, I thought I'll give her a little show. But it doesn't have to go up because it's not just an arm-raising induction, it's an arm-raising test of suggestibility. So, what's suggestibility? A little talk about that. Suggestibility is if you think about how we learn things. Are you more direct? Are you more inferential? We're all sort of on this continuum. We all do both, but some people tend to prefer things. So when you know someone's suggestibility, then you know how to hypnotize them. You know how to give them suggestions so they go into the state. So that everyone can be hypnotized. So if you're thinking, it doesn't work on me, it does work on you. So she's doing the arm raising, and it's going up, and she's getting really thrilled now. It's going up. It's very exciting for her. And she goes, you know, when you're hypnotized, some people feel lighter, their body feels lighter, some people's body feels heavier, and some people just feel like they're relaxed with their eyes closed. And that's all very natural. And again, it's going up, and it's jerking up. And she goes, oh, then when you're hypnotized, you know, you'll hear everything that I'm saying, but your mind might be your conscious mind might be thinking, oh, I wonder if this is hypnosis. Is this hypnosis? Is it going correctly? Is this how it's supposed to go? You're going to be asking those questions, and it's totally fine. So my arm goes up, and it goes up, and it goes up. And then something happens. So that was the first time that I was hypnotized by somebody else. How many people here have been hypnotized by somebody, whether it's a hypnotist on stage or hypnotherapist? Okay, so you kind of know. I'm going to assume that you have not. So we're all beginners here. First of all, who's that guy? Because if I were to walk up here, it was Dr. Jonathan Fisher, MD. I had titles or letters on both sides of my name. You'd go, oh, we trust, and we have doctors, and we trust what they say. But what does it mean, a certified hypnotherapist? Well, it means that I am recognized by the American Hypnosis Association for having gone through a certain program. And I'm wearing a badge, so it makes it official. It says that I am. And what does that actually mean? So NLP trainer, master practitioner. How many people know who Tony Robbins is? Same background, NLP, neuro-linguistic programming. So that's what he does. And a little bit about what I do. So my primary focus areas are health and wellness. Go figure, right? So things like diabetes, other areas of health. Public speaking, that's what we're doing right now. And sexual health, which I have found is sometimes a very big motivator for health and wellness. It got me to be motivated to be healthier. And then it says I am the primary content creator for Mindify apps. There's a bunch of apps out there, and these are the focus areas, and a lot of them have to do with health. So millions of downloads in over 20 countries. I don't know if it's 20 countries. I kind of made that number up. It's as many countries as I can think of, so I just said 20 countries. I don't know. I didn't count them, but a lot of countries. Okay, so I might be oversharing, but this is me again. Why is it all about you? We're here to learn about hypnotherapy. So 6 years old and 46-year-olds. So I talk about, I don't have a doctorate, but my doctorate is in being doctored. So at 16 months old, I had heart surgery. At 6 years old, I was in the hospital for 7 weeks with endocarditis. 18 years old, I was diagnosed as having a stroke. I had open brain surgery when I was 22 to repair an aneurysm. Atrial fibrillation at 40, there was an ablation. None of those I used formal hypnosis for because I didn't know about it. But for the open heart surgery, which was when I was 46, so about 3 years ago now, I did. I prepared a bunch of tracks to listen to preparing for, to listen to to prep me for the surgery and to recover after, so that it turned out that that open heart surgery was the most extensive open heart surgery done at the Maine Kaiser Hospital on Sunset Boulevard. So, you don't have to clap. Okay, so why do I share this? Well, hypnosis, hypnotherapy is different than seeing your doctor. If you see your doctor, you maybe have, 6, 8 minutes. You don't have much time. You see them once a year. There's not a lot of exchange of information. When you see a hypnotherapist, whether it's me or somebody else, there's a lot of time. You get to know them. It's, generally it's like an hour a week. There's maybe contact between them. So we bring more than just a certification. We bring ourselves. So I'm bringing, yes, my background in hypnosis, but I'm bringing the things that I've gone through. It also shows that although I may look young and healthy, thanks again, if you're thinking that. If you're not, I just made it up. It makes me feel good. But I've been through some things. So it's a little proof that maybe I know a little bit about what it's like to go through some things. So it's a getting to know you kind of situation. So the facts. So here's the, when people find out that I'm a hypnotist or hypnotherapist, what do you think the first thing is they ask? You're not going to what? Put me to sleep. What else might they say? Really, like bark like a dog, I get a lot. I once said, or quack like a duck. I had someone say quack like a chicken. I thought, well, that's interesting. That I would like to do. Well, as you learn now, when I did this little story, most people don't know a lot about hypnosis. Now, you guys probably know way more than the average person about what hypnosis is and isn't, because most people think it's something that it is not. So I have to overcome the false identification with people like stage hypnotists, and maybe you've seen them. So imagine this. Imagine they have a hypnotist, right? Imagine if there were a dentist who did a stage show. So they would get people from the audience, they have all these stage chairs up here, and they're like, okay, we get the people to come up, and what we're going to do is we're going to give you Novocaine, then we're going to have you drink this thing, and it's going to spill over, and we're all going to laugh at you. Then we're going to put the mask on you, we're going to give you the nitrous oxide, and we're going to get the drill out there, and we're going to terrify you. Would you go to a dentist? They'd have to overcome the stigma of what we think dentists do. It's the same thing with hypnosis, when you think of stage hypnosis or what you see in the movies or on television. So here I have some facts. So hypnosis has been used for thousands of years, but formally, as you can read, in 1953, the AMA recognized hypnosis as a useful technique in the treatment of certain illnesses and a valid medical procedure. In 2003, the Wall Street Journal said something very similar. In 2016, there were MRI studies at Stanford. Now, basically, they found that something is structurally happening in the brain when you're hypnotized. In general, it's a disconnect from the frontal cerebral cortex, the frontal lobe, with the rest of the brain. So you're not overthinking things when you're giving suggestions. So you actually can go in there at the unconscious level and give somebody suggestions to change behavior at that deeper level. And also, I have this quote down here that if hypnosis by you can do his name, Redondi, I don't know, Dr. Redondi. If hypnosis were a medication, it would already be in all of the hospitals, but it is an approach, and thus it must overcome cultural barriers. That's what I'm talking about when I talk about things like stage hypnosis, media, like movies, television. We have to overcome the stigma of what people think it is and what it actually is. If the next slide will go. There we go, hold on. All right, the science. So, Dr. Sadeghi talked about the risk factors, the modifiable risk factors as you see in the asterisk. That's what we're working on. When I get a referral from a doctor, that's what I'm working on, is these risk factors. And ideally, we have an interaction with the doctor. We have an exchange of information so that I know what she or he wants their patient to eat as far as their diet. And there might be some overlap, there may not be, but we talk about what kind of diet, what kind of exercise is right or wrong for them if they're not able to do it. Things like smoking cessation. I throw in some other things because there are the risk factors we all agree on. But if we're talking about something like let's say type 2 diabetes, although people are getting younger now, getting it a little younger, generally it's for people who are older. And if you're older and you have type 2 diabetes, you might also have what? Chronic pain. Well, if you're in chronic pain, maybe you're a little less likely to go exercise. If you're not exercising, maybe you're staying home, maybe you're snacking. and then maybe you're gaining more weight, and then maybe you're feeling depressed. We're dealing with things like that. So pain management, motivation, stress relief, sleep. Why is sleeping important? Because of cortisol levels. All of these things are the things that there are dozens of studies saying how effective that hypnosis is to help people be motivated to do these things, do all of these different risk factors. That's why clients are coming to see me. Doctors' patients, my clients as I call them, are coming to see me. But one other thing. I'm giving suggestions for all the modifiable risk factors so that people actually do those behaviors. But here's an interesting thing that was in the International Journal of Clinical and Experimental Hypnosis. The multimodal treatment seems especially promising with hypnosis as an adjunct to insulin treatments in the management of both type 1 and type 2 diabetes for stabilization of blood glucose. Another reason that I talked about my medical history is to know that I am not against Western medicine. It's literally saved my life I don't know how many times, as you've seen. I'm constantly working with doctors as far as what do you want them to do as far as the risk factors. And hey, if what I'm doing can help the effectiveness of insulin, great. My personal objective if I'm working with a patient is it possible when working with your doctor to get them off of as many of their medications as possible by doing the risk factors? But I'm also giving direct suggestions for things like glucose. Why would I not do that? Because they're already going in, they're already tested, but if what I'm saying at an unconscious level has an effect on their blood glucose along with taking their insulin, what if they maybe don't have to take as much? That would be a good thing. Increased compliance, and that's what we're talking about with the risk factors. Increase compliance too. Take your medication, be on a certain diet, get the exercise, do all those other things that help improve your success with diabetes. And the last one is improvement of peripheral blood circulation. How many people, if they're on stage, might have a flushed face or have ever had that? You blush, right? An unconscious response. Nobody tries to blush. It's an unconscious response of peripheral blood circulation, or a kind of it. Unconscious. So we can increase blood flow, because let's imagine, well, what's one of the biggest fears with people who have diabetes? Maybe I'll lose a limb. Vision loss, lose a limb, obviously other things with heart and circulation. But losing a limb. But before that happens, you have what? Probably some tingling sensation, loss of feeling, and maybe walking is a little bit more difficult. What if you could help by doing those risk factors, and I'm giving some suggestions with some peripheral blood circulation, so maybe a little more feeling comes in there. So then maybe walking or exercising is a little bit easier. We start shedding some light in the person's life, and that's another thing that we focus on is hope. Is giving people hope in their life, giving people something to, instead of moving away from the scary thing of diabetes and ill health, moving towards something they'd rather do, rather be, in a life they'd rather live. All right. It's no longer a red screen. All right, so how does this even work? The conscious and the unconscious mind. Think of it as an iceberg. It's very similar to that. Roughly, the conscious mind is 10%, the unconscious is 90%. When I first went through school, they were saying 12 and 88. Then I heard 90 and 10, and now I'm sort of hearing it might be more like 95 and 5% of your conscious mind. Conscious mind is the logical, rational part of your mind. It's also the willpower part of your mind. It's the part that primarily, mostly, is listening to what I'm saying now. It's the part that hears, oh, I have diabetes, I should do these things. But why are they not doing them? Because of this stuff. Because of values and beliefs, and then they reflect in your outward behavior. And these are the things that happen all the time. I heard that we have like 90,000 some thoughts in a day, and like 96% of those thoughts are the same thoughts you had yesterday. What are you changing? You just keep rehashing all of these things. So the main thing in this, the main thing is the critical area. It's aptly named. What is the critical area? It's the filter, so that when new ideas are presented to you, the critical area is the logical, rational, reasoning part of your mind that accepts them or rejects them. And that's the idea behind suggestibility. When I said some people learn directly, some people learn inferentially, that's the critical area, is what are you suggestible to? In hypnosis, we bypass the critical area. There's going to be a talk on Tuesday where I can go way more in depth on how this is used, but everything happens in this 90%. Let's give an example. If somebody came to me and said they wanted to quit smoking. Now let's say they've been smoking for decades. Now I might ask them, so, why'd you quit smoking? Or why'd you start smoking? They might say, well, when I was like 18 or whatever, I thought it'd be cool. And they're like figuring out how to do it or whatever, and like what it looks like. And I wanted to hang out, I wanted to be cool, I wanted to hang out with the cool kids, I wanted to maybe curb my appetite. And then later it was, I continued to smoke because I get smoke breaks, and maybe that's when you hang out on the sidewalk or outside with the boss and you get that inside information. Well, as an adult, maybe decades later, do we still want to be cool? We still kind of want to be cool as adults. Do we want to curb our appetite? Sure. Do we want to have advantages at work or other places? Yeah. But we know that consciously that's not the way to do it. It doesn't matter, because unconsciously is what you told it decades ago. This is the way you do it. This is how you become cool, how you become rebellious, how you become unique. Yes, there are some addiction qualities, and there are some physical addiction qualities, and we work on that as well. But there's also a mindset thing. There's also a belief system thing that we work on. Same thing with diet. The belief of this or that is nutritious, that changes over the years, so we work on those beliefs. Because if it's programmed in this 90%, you will do it. You can't not do it. Anything above that, the 10%, is willpower. All right, who doesn't like cute dogs? So now you're thinking, so John, what's the next step? So how would you add hypnotherapy to your diabetes or healthcare plan? I use plan because plans are what? Plans are fluid, plans change, plans can be altered. That's what it is. You change one thing, and then we kind of see how that works. And you talk with your doctor, and you get more blood tests, and they measure they take more tests, and they kind of see where we are with respect to blood glucose and other levels in your health. Plan. Now, step one, find a certified hypnotherapist. Maybe it's me. Maybe it's like, I'd rather see a female, or I'd rather see somebody else other than this guy. That's fine, but find a hypnotherapist and find someone that you'd resonate with. That's why I told you about my background, because they're bringing a lot of their background other than just their training to your sessions. Train your doctor. What does that mean? It's like how to train your dragon, but how to train your doctor. So I say declarative statements. What does that mean, John? It means instead of saying something like, asking your doctor, like, hey, what do you think about hypnotherapy? Or do you think I should use hypnotherapy? Don't state it that way, because most doctors, they don't know. At best, they know that, well, maybe it's used for quitting smoking, and go do that. Say something like, I'm going to go see a hypnotherapist. How best should I do that? Get a signed release, get a release of information so that your doctor and I can talk, and we can have this three-way conversation where we can actually get you the best care and be the most supportive to you being where you want to be. That's the ideal way of doing it, is to really get at the grassroots of it, because as it is right now, I don't believe there's any insurance company that pays for, even though there's tons of studies backing its efficacy, pays for hypnotherapy. So it is an out-of-pocket expense. But if we start getting more and more doctors understanding that we truly are the do-no-harm modality, we give suggestions, positive suggestions, and you're either going to accept the positive suggestions that you want or you're not, and that's what we do each week, is we figure out, well, what's working, what's not working when we gave you suggestions, until you get the results, and we're backing up what doctors are recommending you're doing anyway. We truly, as I say, the do-no-harm approach. So declarative statements, say this is what you're going to do, how best should I do that? I throw this in here because this is what I tell my clients, is ask questions and get answers. So when you go to your doctor, make a list of questions, and don't leave until you get the answers. And ask things like, these medications that I'm on, do any of them have interactions with each other? Is there anything that I can do to start getting off of some of these medications? Why not? Why would you not do that under your doctor's care? Seek out and assume the best case scenario. This has happened to me many times, where the doctor might say, give me the worst case scenario, the worst case. In fact, I was told by the best surgeon that Kaiser has. He said when I was meeting with him prior to my heart surgery, yeah, Jonathan, we can do all these different things, like these 7 different things, reconstruct your heart, and do another heart surgery in the future, and I can get you to 70. Well, some of you are probably older than 70, and I know the older I get, the younger 70 seems. So my first thought was, go home, undo that. Because if I were to have asked him, so like 71 is totally out of the question, what would he have said? Well, that's possible. And if I would have said 72, clearly, I'm dead by 72, right? Wait, no, yeah, I mean, Jonathan, you might make it to 72. So you're telling me you're just going to wipe away 2 years of my life. So I reframed these things, and knowing that not only are there many things that I can do for my own risk factors, and we all can, but technology changes, science changes, there's plenty of time. So seek out and assume the best case scenario. Ask them, what's the best case you've ever seen with someone in my situation? Assume that's you. Assume you're the best case situation, you're the best case scenario, and do those things. So how can I learn more about these things? I have a free webinar, which if you look at my cards, you sign up and say, yes, I want the free webinar. I can send you that. It's like an hour long. It talks about many of these things, but in more depth. You get a free hypnosis track to listen to reinforce it, and you get a free strategy call with me. You can do that. I also, on my website, have a bunch of free tracks to listen to. And Tuesday, we are doing a hypnotherapy class, so you can ask as many questions as you want. We may hypnotize some people, and we'll get far more information than I could possibly provide here. So, my information, that's the webinar at the bottom. I think you can read that. So my arm's on the table. And it's about here. And what I'm feeling is this tingling sensation that's happening, and a deep relaxation that's flowing over me. First time I've ever been hypnotized. And my arm actually kind of moves by itself now and touches my face. And I hear her quietly but enthusiastic go, what do I do now? What do I do now? What do I do now? Because the teacher's walking around helping all the different students in class. And she's like, what do I do? What do I do? I'm thinking, just say anything. Say sleep, say deep sleep, say ta-da, I don't care. Just say something. And so she does. Deep sleep. Now, I don't know the suggestions that she gave me, but now, if I could pick and choose, what I might want her to say would be something like Joseph Campbell, the mythology guru, might say, that whatever your age, whatever your situation, answer the call to adventure, however that looks for you. Follow your bliss, and if you don't know what it is, find it. Because as long as we are breathing, even if it's well past 70 for some of us, as long as we are breathing, we are still on the hero's journey. Make it the most heroic. Jonathan Fisher, hypnotherapist, certified hypnotherapist. Thank you.
Thank you, Jonathan. Let's give Jonathan another hand applause. Thank you. That's really exciting. So as Jonathan said, there's going to be some flyers because there's, in the community center, there's going to be a event where we have a hypnotherapy. It's in, I believe, the Pine or Elm Room, but it's on the flyer. So at this point in the presentation, we're going to ask everybody to go out and get some lunch, and then come on back, and we'll do some more, have some more discussion about hypnotherapy. So lunch is right outside, and that's catered. It's courtesy of Zad Catering, and it is diabetic friendly. There is 2 pieces of bread that are pita bread, but we just advise you they're wheat. They are wheat. Somebody had asked about wheat. So go ahead out there. There's water, coffee, and then come on back and we'll talk some more about hypnotherapy. Okay. So for the remainder of the program, Jonathan will be doing an example of a hypnotherapy session. So he's going to ask for a volunteer, and we're going to, after you're finished your lunch, we'll have him come up here and do an example. We also are going to have, after his completion, we're going to have a raffle. We have a few things to raffle off. And we're going to take the list that we signed in on, and we're going to use that to draw the winner. So stay tuned, and I hope you're enjoying your lunch. How was your lunch? Good? Yes. Excellent, excellent. Yeah, we wanted to make sure we kept it healthy, fresh, organic, and we have the best caterer, so we never worry. Jonathan's eating lunch too, so as soon as he's done, we'll get him back here. There's chocolate mousse. That's your dessert. That is not friendly, diabetes friendly, but it is delicious in case you want to give it to your neighbor if you don't want to have it yourself. So has anybody heard of the keto diet? A lot of information about the keto, right? And ketosis is being recommended for, it's a high fat, lower protein, and very, very low carb. That's what ketosis diet is. Your body produces ketones and uses ketones instead of glucose for energy. And those of us that are neurological disease, a lot of times the brain does better with less glucose and using fat for energy as opposed to sugar. So we are part of the Healthy Brain Club, the CCA. So I always like to mention that Dr. Trin comes and speaks on different brain health issues. And I know we've spoken about ketosis in the past. So I'm not sure how that works for the diabetes community, but for sure for the neurologic community, there's a lot of data being put out there about the ketosis diet. So 2 more minutes, and then I'll have Jonathan come back up. We're going to actually get a demonstration of a hypnotherapy session. So I'm going to invite Jonathan back up. I'll actually give him the microphone from here on out, and he will take over. And then the very last thing is we'll do the raffles. So hold on one sec. So let's welcome Jonathan back again. Give him a round of applause. Woo!
Yay! We do need a table and some chairs, so do we want to just do it down here, or I don't know if people can see. Pay no attention to the woman behind the curtain. What movie is that sort of from? Yeah. No. So we are going to do a hypnosis demonstration, and it is not like stage hypnotism in that you will not be made to do something that you don't want to do. In fact, we're only going to hypnotize you and give you very positive, general suggestions, sleeping better, feeling good, just so you kind of feel, you know what it feels like. Some people, when they describe what hypnosis feels like, they say it's a little bit like a mental or emotional massage. It's a pleasant feeling. So if people want to be a volunteer, we would love that. So possibly, yes? Have you been hypnotized before? Okay. We can do it. It'll be very similar to what you heard me describe in my little story. So when we had a table of some sort? All right. Oh, there's the flag that we were supposed to be looking at. That's a metaphor. Your country was there for you the whole time. Yep. Okay, so. All right. No, how should we get this set up here? Let's do a little rearranging. Yeah, a little bit. It doesn't have to be that dramatic. Okay, so you want to do it? Do you ever sleepwalk, or have you ever been sleepwalking as a kid? No? Okay. So let's come on up. So we're not even doing it the way that stage hypnotists would do. They would do a whole, put your arms out, clap them together, stuck. We're not finding the most suggestible. I do not know what her suggestibility is. Doesn't matter. Watch your step. Okay. And what is your name? Carol. Okay. I'm Jonathan. Nice to meet you. Okay. So we'll have you sit in, what's that? Yeah. Oh, yeah.
If the AMA approved hypnosis, why don't any of the health insurances cover it?
I don't know, but that's why I recommend having that dialogue with a doctor, because at some point, I was talking to my cardiologist in December. In fact, I was supposed to go in for my 6th month, but it turned to be like 18 months just because I just didn't go in. Because I was fine, I felt great. And he said that Kaiser was thinking about adding hypnotherapy and other things into the Kaiser plan, but they decided against it, but I'm thinking the foot is in the door. So I don't know why, but if a place like Kaiser is thinking about it, other places are, I think eventually it will be, because again, it's the do no harm. I don't know why they're not. Anyway, so I hope that they do. They should. But we're going to have you sit in the blue chair. The blue chair. Okay. So normally in a session, I would, for me anyway, a typical session would be, the first session is usually about an hour and a half. So it's a longer session because we talk about what you would be here for. We talk about what hypnosis is and what it isn't, but you were here, so you know what that is now. You know sort of what to expect or what not to expect. You'll hear everything that I'm saying, right? You're not gonna, well, that's okay, that's all right. When you're on stage in front of people, so, and there's like spotlights on you, so that's okay. What's that? Oh, can we turn them down a little bit? It's like there you go. Is that better? Way better, okay. Okay, so normally we would talk about why you're here, we talk about what hypnosis is and what it isn't, I draw the little thing and whatever. And we would test your suggestibility. So let's put your hand on the table, or your whole arm, sorry. Very, very literal, I like that. See, I'm listening to everything. So I did say hand, and you put your hand, very good. All right, let's have you move the chair a little bit closer to the table, and then just kind of do this with your arm. Okay. Great, and just rest it down there. And I'm just going to ask you a few questions. And so no more talking. Although, is there any general suggestions you'd like to have? Like sleep better, that's okay, right? We all can sleep better. Okay, anything you'd like to have? Just general. We want to get personal, so any just general.
Probably stress and also judgment from others.
Perfect, and we could all use that as well. So if anyone wants to play along at home and put their arm on their table, that would be okay with me. But then you can't leave, because I don't want you going, and then you leave, and you're like maybe in a suggestible state. So we don't want that. So you have to stay. Here we go. So, okay, just to take a couple of deep breaths. Okay, I'm going to go over a few things just to remind everyone. So you'll hear everything that I'm saying. Everything's going to go exactly as it needs to go. At some point, I might touch your arm. At some point, if it's okay, I might touch your forehead. Otherwise, you're just free to relax as much as you can in this blue chair, okay? All right. So just looking at me, and I'm going to ask you a few yes and no questions, and just nod for yes or shake your head for no. If you don't know the answer, just look at me and I'll find the answer, okay? And we sort of asked this, but have you ever walked in your sleep during your adult life? Do you dream? Do you remember your dreams? Were you more influenced by your parents' tone of voice than what they actually said? No. Okay. So I would be asking a series of like 40 questions to get the individual's suggestibility. I'm not going to go through the whole thing, so we're mainly just going to go ahead with it. So look down at your arm right there. And how well can you visualize or imagine? You can answer this out loud. Can you visualize or imagine? If I were to say you imagine a pink elephant, can you kind of imagine what that looks like? Okay. So look at your arm on the table, and when you have a good image of your arm resting on the table, just closing your eyes. Great. Just holding that image of your arm resting on the table in your mind. And if anyone else is doing it as well, make sure that your elbow is also on the table. So you want your entire elbow to the fingertips on the table, anyone else watching. And just holding that image of your arm resting on the table from the elbow to the fingertips. And now add to that image, imagine that there's maybe it's a string or a rope, I'm not sure what it is, but it's tied to a bunch of helium balloons. And it's tied to your wrist. When you can imagine that in your mind, these maybe dozens of helium balloons, and you can imagine that tied to your wrist by a string, just nodding your head yes. Great. And you're going to notice a couple of physiological changes happening. And it's okay to adjust yourself, move around, get more comfortable the whole time, that's fine. But you're going to notice a couple of physiological changes. First of all, you might notice a change in your breathing. When you notice that, just nodding your head yes. Great. And you may notice that there's a dryness of your lips, your mouth, perhaps an urge to swallow. Whenever you notice that, just nodding your head yes. Great. And you might notice that, great, you may notice that your eyes beneath your eyelids have a tendency to move around. And again, just nodding your head yes. Whenever you become aware of that, just nodding your head. There is a change in breathing again, that's great. And again, then moving your attention to that string on your wrist, imagining those balloons, and then noting from the elbow to the fingertips, a light feeling in that arm. A lightness in that arm, a floating feeling in that arm. And you may feel it as first tingling sensations in your forearm, your hand. You may feel it as a tightness of the bicep. That's right. Your arm lifts up, a lifting, rising up. A tightening of the bicep as your elbow pushes into the table just slightly. That's right. A lifting up, higher and higher, a lifting and rising feeling as your elbow pushes down slightly. The arm floats up, a lifting and rising, floating feeling that tightness in the bicep as it pulls up. That's right. A lifting up, feeling your feet on the floor. A lifting and rising up. A floating, light feeling. That's right. Feeling your left hand resting on your leg. And you're just focusing on me, allowing other sounds just to drift off to the background. Feeling that change in breathing, the dryness of your throat. A floating up, a lifting and rising, floating feeling as the arm just lifts and rises. That's right, listening to my voice. Rising up with each inhale going up. That's right. Floating up. Feeling your back resting comfortably. And your conscious mind may be thinking of other things, wandering, drifting, and that's fine. Because if your conscious mind is here and asking questions and wondering, that means your unconscious mind is also hearing everything at that deepest level as it lifts up, a floating, rising feeling. All the other sounds move into the background, a floating up, a lifting and rising feeling. That's right. Feeling that tension in the bicep. Feeling that light pressure in the elbow. And perhaps your left arm becomes even heavier, I wonder, as you're just listening to me. And that questioning mind, the questioning conscious mind can keep doing that. That's fine. It can wonder what's happening or what's supposed to happen next. And that's just the part of us that keeps us stuck. As the arm lifts and rises, a floating up, a pulling up, lifting and floating, higher and higher, a lifting, floating feeling. That's right. Higher up, pulling on the bicep, feeling that tension in the bicep. As you're becoming closer and closer to your peak suggestibility, and that just means the peak ability to learn at an unconscious level. As we're just talking to your unconscious mind, as it imagines those balloons floating up to the ceiling, higher up, that's right, floating and drifting, feeling those changes in the breathing, feeling the eyes moving beneath the eyelids, becoming closer and closer to your peak suggestibility, and that's just your, again, your peak ability to learn at an unconscious level. Going even closer at that, even deeper, and keeping your eyes closed, and deep trance. Just allowing the arm to go down now, perhaps even feeling heavier in that arm. Going even deeper as you imagine the numbers from 5 down to 0 floating by in your mind. At 5, 4, becoming more relaxed with each number. 3, 2, 1, 0. Keeping the eyes closed, going even deeper. That's fine. And in a moment, I am going to count up to 3, and we'll have you open your eyes again. But you're not looking at anything specific. Just keep your eyes closed. That's okay. Keep them closed as you go from 5, that's right, taking that breath, down to 4, 3, 2, 1, 0. Deep trance. And I want you to visualize or imagine in your mind a place that you love to visit. Maybe it's a vacation spot. Wherever that is in your mind, just going there now. When you feel that you've arrived, just nodding your head yes. Wherever that might be. It can be a place you've been before or one you're just making up in your mind. Whenever you've arrived, just nodding your head. That's right. I want you to use all of your senses. Imagine yourself being there. Seeing what you would see through your eyes. Feeling what you would feel. Looking down at your feet, and maybe your shoes have changed. Feeling what you're standing on. If there are any smells in this place. Perhaps there are even some tastes. Being in that place right now and moving around that place. Really experiencing it. With all the senses that you're able to. Knowing that however you're experiencing it is exactly how you're supposed to be experiencing it right now, in this moment. That's right. And then just allowing this image to dissolve and imagining those numbers from 5 down to 0 going by. At 5, 4, 3, 2, 1, 0. Deep trance, keeping the eyes closed, going even deeper. Each and every time that deep trance is suggested for hypnosis, with your permission, allow yourself to enter quickly, calmly, and deeply to this depth or deeper, because that's what happens, is the depth or the suggestibility, the relaxation, changes as we move through. Sometimes it's a little lighter, and sometimes it goes deeper. As we slow the brain frequencies and talk to that deeper part of the mind, the part that has the answers. The part that knows exactly how to fix that problem. Just coming in touch with that part right now. And then imagine yourself standing at the top of a staircase of 20 steps. And this could be a staircase you've seen before, one of your own imagination. But it's a well-lit staircase, a sturdy handrail, It's very easy to go down. It's very easy. In fact, you know that with each and every step, you can become more relaxed. As you feel each step beneath your feet, when you move down those 20 steps, becoming more relaxed at 20, 19, 18, 17, 16, 15, 14, 13, 12, 11, 10, and just going to that special place again, that vacation spot. And going to a place there that's even more special, that's even more important, that's even more relaxing, that's your place. And when you arrived at that most special place, that most personal place that recharges you as it relaxes you, just nodding your head, yes, that's right. And being there now, and notice that you're sitting across from yourself. You're sitting across from the version of you that has those answers that you're looking for, that has those abilities, that has those behaviors, that has those reactions. And maybe that version of you looks a little different. Maybe it's sitting up a little straighter, looks a little stronger, a little more powerful, a little more confident, doesn't she? And just smiling at her, because she gets it, right? And because this is you, feeling yourself getting up and actually sitting within her, you're merging with her, and feeling that new confidence, that new assuredness, that new strength that you've always had, and you're just now acknowledging, aren't you? Find yourself perhaps walking now a little bit differently, with more power, more confidence, being more sure of yourself, having those answers, having those new behaviors that you're just allowing to come forth because they've always been there. And giving yourself permission to have venting dreams tonight in the early morning, dreams that release any blocks to having those new things, to having those behaviors. Dreams that you'll have in the early morning, and it doesn't matter if you remember them, because they'll just release those old blocks. They'll just let them go. And then continuing down those steps at 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0. Keeping the eyes closed. Deep trance, going even deeper. Each and every time that deep trance is suggested for the purpose of hypnosis, with your permission, allow yourself to enter quickly, calmly, and deeply to this depth or deeper, and allow your physical body to relax. And in a moment, I'll be counting up from 0 to 5. When I get to 5, your eyes will be open. You'll no longer be suggestible. In fact, you may be less suggestible to the negatives in life than you've ever been. More resistant to the negative things, more resistant to the things that don't support your positive growth. You'll have this resistance as all the sounds around you just relax you even deeper at 0, deep trance. Letting all those suggestions take hold. And do they take hold because I suggested them, or because these are the suggestions that you actually want because they're in your betterment? And then moving up to 1, 2, 3, knowing that all things work out to the positive. And 4 and 5, eyes open, wide awake. 1, 2, 3, 4, 5, eyes open, wide awake. Thank you. About here, right? Really? Yep.
I was aware.
Yeah.
Well, it helped when you touched it too. Yeah.
Any other questions, or do you have any questions, or?
I mean, there were times that I just feel much faster, and then it would slow down again, and yeah, it was pretty unique.
Yeah, like I say, I usually do a full hypnotic induction, meaning I'm talking about it, I'm testing their suggestibility, so I really find out where they are suggestibility-wise as far as how to give them suggestions. And spending a little bit more time, but yeah, good job. We just kind of sped it up a little bit, but that's fine. That was fantastic, so. All right, give her a hand. How about that, being on stage? Yeah. All right. Anybody else have their hand go up? I was really mostly focusing here, but cool. 1, 2, 3, 4, 5, eyes open wide awake if anyone has any hypnotic stuff going on. So questions for anybody? Very relaxing? Good. We're slowing down the brain frequency. Yeah. Is this one?
Testing, testing.
How do we get the hypnotherapy session covered by insurance?
Yeah, would that be great? So talk to your doctors. If the more we do, just like years ago, remember when you couldn't find like organic food anywhere? You had to go to a specialty store, right? The more people buy organic, you vote with your money. You vote with what you want. The more all of a sudden organic is everywhere. You go to like the dollar store, they have organic food. It's everywhere. I don't know if you want to buy it from the dollar store, but whatever. But you can go anywhere and find organic food. So talk to your doctor about hypnosis. Like, and again, tell him or her that you want it. I'm going to go do it. And you need a release of information if we're doing something that's medical. And have the doctor sign a release so that your doctor or somebody else's doctor and I can talk. Because in that conversation, they get more open. They refer more patients to we as hypnotherapists. They get better results because we're enforcing all the things that they're working on anyway. It's just that we're spending way more time. So, yeah, you really, the best thing is just is a grassroots, just keep bugging them. And at some point, like the Kaiser, foot's in the door, they're thinking about it. If they're thinking about it, it's going to go that way. So.
Am I on?
Yeah.
Do you hypnotize yourself? And if so, how does that work?
I do, and I don't actually, it's weird, it's like I don't recommend self-hypnosis. Self-hypnosis is when you're just sitting there telling yourself some of the things that I would say here, but you're telling themselves with your internal voice, your self-talk. I don't recommend that because at some point, we all have negative self-talk. So I would recommend only doing hypnosis in what we would call hetero-hypnosis. It just means two people. Even if you record your own voice, which is what I did. I've done it many times, but for my heart surgery, I recorded many tracks that I listened to, including I listened to a track for myself during the surgery, because it's open heart surgery, it's a major surgery. And what I did was I gave myself suggestions that when they're doing the surgery, first I talked to the surgeon, I said, do you play music? He said, only if you want to. I said, I don't want to. Because I didn't want, my body is not going to feel it, but my unconscious might be aware. Or why not assume that it is? So I didn't want music that might trigger me. I gave suggestions saying that whatever people in the operating room say, I hear it as positive. I hear it as, oh, we can't believe this surgery's going so well. We've never had this amazing outcome. We have all the time in the world. When we make an incision, there's no blood. We can easily do all these things. They wanted to do 7 things, and it was a window of opportunity on the heart-lung machine. They may not have time to do all these things. So I did. I record sessions myself to do self-hypnosis. But I don't generally do it. I do meditation, where I just clear my mind, but hypnosis, I record and listen to it. So, what's that? That I can't, or hypnosis can't? Well, hypnosis is very good with pain management. It's very good with chronic pain or acute pain, but usually acute pain. There's a reason. I've never had to. I don't believe in knocking on wood, but I've never had to. So, but I did a little bit because there was some pain with the incision, but I prepped so much that I didn't need to listen to it for pain. But
thank you, Jonathan, very much. Really appreciate that. We're going to go to the rest. Let's give Jonathan a round of applause, please. Thank you so much. And I invite you to come on Tuesday to the community center and have a more intimate view of the hypnotherapy, which will be there. At this stage, we're at this point in the program, we're going to do our raffles. So Deborah's going to handle our raffles for us. Here you go, Deborah.